Good afternoon, everyone. I'm Dr. Ashby Wolfe, and I'm a family physician serving in the role of Regional Chief Medical Officer at CMS. I actually serve in the Seattle and San Francisco offices, but work across all of our locations and with our colleagues in DC and Baltimore in implementing the Medicare and Medicaid policies and programs across the Western US and the Pacific territories. This includes getting to hear firsthand from clinicians about where they're seeing success in our programs and where they're experiencing obstacles. And I'm truly happy to be here with you today to welcome you to our discussion on protecting healthcare workers from burnout and violence. Priority 3 of CMS's recently published Optimizing Care Delivery framework is to address well-being and experience for healthcare workers across the healthcare enterprise. As background for anyone who may be new to this topic, according to the Centers for Disease Control and Prevention study, the healthcare workforce has been increasingly experiencing higher rates of burnout and harassment in the workplace. According to Bureau of Labor Statistics, healthcare workers are 5 times more likely to sustain a workplace violence injury than other professions. And in 2018, 73% of all non-fatal workplace violence-related injuries involved healthcare workers, 73%. There's also data from the American Medical Association showing that female physicians reported burnout at a higher rate than their male colleagues. And as we'll discuss, data from the Agency for Healthcare Research and Quality has found that burned out clinicians are more at risk of making errors or practicing unsafely. Here to talk about this and what we can do to address these challenges are colleagues Kathryn Spates and Dr. Deutsch. Kathryn is the Executive Vice President for Public Policy and Government Relations at the Joint Commission, where she leads the Government Relations Office in Washington, D.C. Before she began her government relations and legal career, she spent many years in clinical care as a nurse and an acute care nurse practitioner. Dr. Deutsch is a medical officer with the Center for Quality Improvement and Patient Safety at the Agency for Healthcare Research and Quality, or AHRQ. She is an experienced pediatric otolaryngologist with expertise in simulation, resilience engineering, human factors, and patient safety. So I'd like to welcome both our speakers and thank you for being here with us today. So as we heard from Dr. Perlin in his comments earlier today, violence should not be a part of the job providing care to those seeking it, nor should it be a part of the care or healing experience. And so my first question to you, Kathryn, as Dr. Perlin alluded to, in 2022, the Joint Commission implemented workplace violence prevention standards. Can you talk a little bit about what's included in those standards and what's useful for people to understand about them, even if they're not applying for accreditation through JCAHO?
Yeah, first, I just want to say thank you so much for having me and for having the Joint Commission being part of such a very important topic. So as somebody who's worked as an emergency department nurse for over 20 years, I really know personally what it feels like to be on the receiving end and to work in an environment where workplace violence is occurring. And I'm not going to highlight a whole bunch of statistics here for this audience because I'm sure, unfortunately, I know that many of the my healthcare worker colleagues and many of those in the audience have their own personal story related to workplace violence. But I do want to just talk about a little bit what the Joint Commission is doing on this topic. So as Dr. Perlin, the Joint Commission's president and CEO, already said earlier, workplace violence should not be part of the healthcare environment for workers and for patients or for their families. So as was touched on earlier, the Joint Commission introduced new and revised standards for hospitals to address workplace violence in 2022. And this is really due because we are hearing about increasing threats and the severity of violence against healthcare workers. However, one of the problems that we're hearing about as well is that the prevalence of workplace violence is really underestimated because there's underreporting, and there's been significant underreporting for a long time. And so we're hoping with these standards that they're really going to help address that gap in reporting and also, prevent some of the workplace violence that we're hearing about. And what the standards really do is that they touch on environment of care, they touch on staff training and leadership accountability. So taken as a whole with these standards, they push organizations to review workplace violence risk specific to their own organization because organizations may have specific risks that are unique to their organization. They also call on organizations to take action to prevent those risks. And really what's key is measuring and monitoring progress on efforts to reduce violence. These fundamental actions can really be replicated not just in hospitals, but also in the home health setting and the behavioral health space as well. And we're implementing standards in those areas as well. One thing I do want to highlight with our standards that I think is just really key and critical for the healthcare audience to hear about is that the definition of workplace violence is intentionally broad. And it's not about just physical violence, but it's also the verbal and nonverbal other types of violence that we hear about as well in the healthcare delivery space, such as aggression, threats, intimidation, and bullying. And so really, the key concepts with these workplace violence prevention standards is that we have to look at the whole landscape of workplace violence that healthcare workers are experiencing, monitoring, implementing some best practices, training, and really making sure we're making some progress. The other thing that I want to highlight as well is for healthcare organizations that maybe aren't seeking accreditation standards, we also have a resource page that has tons of resources for healthcare organizations, for workers that really, they're structured around workplace violence prevention programs, but you can also take a lot of those really key themes from the healthcare workplace violence prevention resource page and take some of those tools or the data collection and implement them in your own organization, even if you're not seeking accreditation. So hopefully that gives you just some insight into our standards and what we're doing at the Joint Commission.
Thanks, Kathryn. And I think your comments with respect to the fact that violence can really manifest in many different ways. It's not just the physical violence that people experience. And knowing that organizations that are not seeking accreditation can also leverage some of these resources is really critical. Let's turn to you, Dr. Deutsch, and I want to just highlight for those of you in the audience that aren't aware, at the very end of last year, AHRQ released a notice of funding opportunity titled Systems-Based Approaches to Improve Patient Safety by Improving Healthcare Workforce Safety and Well-Being. And in that release, AHRQ wrote that patient safety really requires a foundation of safe and healthy healthcare workers. So Ellen, can you tell us a little bit about what AHRQ is hoping to learn through this notice of funding opportunity? And what do we know about the connection between patient safety and healthcare worker safety?
Sure, that would be my pleasure. And thank you also for including us. AHRQ and CMS work together on many projects. We're very excited about this notice of funding opportunity. It has gotten a really robust response. So I think it has resonated with people. As we know, and as you've heard throughout the day, when healthcare workers are burned out or suffering in other ways, patients are also adversely impacted. So the purpose of this NOFO is to help us understand whether improving healthcare worker well-being and safety can also lead to improved patient outcomes. Many of the interventions that are now focused on healthcare workers are aimed at helping the healthcare worker cope with the circumstances around them. And this is very important, but as you've also heard this morning, this is not the whole picture. We also need to improve the systems that healthcare workers work in and around and despite and because of. We know that healthcare workers are well educated and they're motivated and they want to provide the best care. The applications to this notice of funding opportunity can focus on improving or fixing the systems that impede healthcare workers' ability to do their job and deliver the best care possible. It can also focus on understanding and augmenting systems that empower healthcare workers and enable them to provide the best quality care that they want to provide. The other piece of this NOFO is that the voice and unique knowledge of the healthcare workers who do the work, whether they're frontline, whether they're administration, whether they're executive, that this unique knowledge and unique voice is essential to understanding how work is actually done, which we know is sometimes different or often different from work as imagined. So it's important also in the NOFO to complement the healthcare worker knowledge with the knowledge of experts in safety. And these might be engineers with human factors or resilience engineering or systems or industrial engineering safety expertise. This could be social scientists, this could be architects, but the idea is to bring together these complementary fields of knowledge to come to the best answers.
Thank you so much. And I think your summary really illustrates that violence can be experienced so differently, and that people's experience, there are physical, psychological components, but the understanding of the work that people are doing is really critical. Let me tug on a thread there and ask you both, just for your brief comments around how those who are listening today might approach the challenge of that understanding of just what violence might look like to people in their organization. Kathryn, I don't know if you have some suggestions around what the requirements are within the workplace violence prevention standards that you mentioned, or Ellen, your thoughts on that?
Yeah, I mean, I can jump in here and just highlight for you. I think some of the great lessons that we've learned about from our healthcare organizations as we've implemented our standards is I've heard from organizations that have implemented actually a workplace violence planning and control committee that's really monitoring and tracking trends within their organization. So I think that's a really great example of something that healthcare organizations can do. And then also another really good example is also implementing a response team that's specifically trained on de-escalation practices is another great example. And then another thing too that I think is key and touches on a little bit what Ellen was saying as well is just peer-to-peer support in the healthcare environment. I think is just really critical. For a long time and many years ago, we just didn't talk about healthcare worker violence, or you would experience violence and it was just part of the job, right? And that is not how it should be at all. It should not be part of the job, and healthcare organizations should put in really think about putting in best practices around this, and one of those could be that peer-to-peer. So healthcare workers feel like they have somebody to talk about what they experienced, what it felt like for them, and how they're doing after the fact, I think is key.
And I'd like to add something to the resources, the great resources that you've already mentioned, Kathryn, and that's the use of simulation. Yeah. Simulation can be a really useful tool. We can use it to help people learn allyship or learn de-escalation, how to function in teams, if necessary, how to restrain a patient in some circumstances. And simulations, simulations in situ, in which the simulations take place in the actual patient care locations, using not just patient care providers, but security and all the other people who may be involved. Simulation in situ is a great tool, and to learn how things actually unfold in your local patient care circumstances. Sometimes if you do this, you might want to use an expert in behavioral health role-playing as a patient, or role-playing as a family member or a coworker, depending on what you're trying to model. Then you can explore not just the interactions, but the physical environment, the response protocols, and you can elucidate or surface the hazards that are being seen by the frontline people that don't always show up in other methods. And then again, the important piece of simulation is debriefing, and you would want an expert facilitator to help debrief, but there are a lot of lessons that can be learned by conducting simulations. Lessons and also steps for improvement.
Great points. Thank you. Yeah, go ahead, Kathryn.
We're going to put in the chat our resource page, and our resource page, we hope to continue to update that with great examples and best practices that organizations are doing on this topic. So I do just want to plug, if any of the healthcare organization audience here have any great examples, we're happy to share this with other organizations as well, and they can send those along.
Fantastic, thank you. And as we wrap up, thinking about the fact that workplace violence, the experience of it in whatever way it manifests, can be quite challenging, can be very intimidating. It can be difficult to know where to start to move forward. And I think both of you have given us some wonderful examples of things that sort of at the organizational level can be used to move forward. I'm just curious for your thoughts in the last moments together. What gives you hope about moving forward, given the circumstances under which people experience violence can feel very dark? Just curious your thoughts there.
Yeah, I'm happy to chime in here first. I think what gives me hope is that we're continuing to have this conversation. You know, as I mentioned earlier, you used to not talk about it. You didn't talk about clinician well-being. You didn't talk about, you know, what you experienced. I think the fact that the conversation has started and it's continuing, that gives me hope. And I do think with our standards, with some of these other strategies that we're hearing about, that there will be movement, and we already are seeing that. So I think it gives me hope that we're continuing to have the conversation, and it's a critical topic, you know, for healthcare organizations, for healthcare workers, for policymakers. That gives me hope.
And I think healthcare workers want to do a good job, and they will figure out ways to do this. This needs to be multi-level. It has to be the front line. It has to be the administration. It has to be the executive leadership. But I think together, as Kathryn said, we're talking about it. We're paying attention to it. There are tools out there. And so the healthcare workforce itself is a mighty power.
Thank you so much. I think that is a perfect way for us to conclude our session today. I want to thank you both for your time in preparation and during our conversation for such thought-provoking discussion. So for our audience, next we will have a 20-minute break. And when we return, we will hear from our next panel on ensuring safe, coordinated, and timely access to care. And that will be moderated by CMS Director for the Office of Minority Health, Dr. Martin Mendoza. So thank you all very much for your kind attention, and we'll see you back in about 20 minutes.